Hello everyone, welcome to the class on the pharmacology of anti-emetics. Sorry, it's raining outside, so I thought it would be a good timing to also record the condition of the world outside as well. Right, so here we'll be talking about anti-emetics. So anti-emetics in a very common layman terms is about medications that stop vomiting because emesis refers to vomiting. So vomiting is a response that is pretty complicated, as you can see in the diagram over here. So before we understand how the drug works and where it acts, you have to understand a little bit about the background of how our body induce the effect of vomiting, right? So vomiting, there's two main components. One is purely by the brain, right? So there's this particular part of the brain called vomiting center. So, and there's another part which is the response from the gut. So, in very short terms, simple terms in a way, you can see that the response from the gut in a way, it's like, for example, if we've eaten something toxic, for example, which is not so clean, maybe, it's like food poisoning stuff. So it sort of feedbacks to the brain and says that, hello, we have to get all these things out of the body. So therefore, this arrow goes and sends the signal and says that, okay, we should go for a vomit sensation. Right, so there's also other components that fit into it. So one of it on the left here is vestibular apparatus. So this refers mainly to our inner balance in the ear, right, in a way, so that, for example, this is what we call, in a way, motion sickness in a way. So like, for example, what we see and what we perceive in the brain sort of doesn't match very well in terms of its motion, right? So the person might feel a bit nauseous-ish feeling. And also there's a chemoreceptor trigger zone. So this is mainly related to the chemotherapy base, so which activates this like toxic substance-ish, triggering this part of the brain, therefore inducing the vomiting sensation, right? So this is in general the few main components of the vomiting. There's also another one which is a little bit more hormonal one, which links to the pregnancy-related nausea and vomiting. Right, so you can see that if you look at the tab on the medication, so you can see different medication acts in different places. So again, reflecting that different medication would be more useful towards a certain type of vomiting response or cause of vomiting. So you need to match that accordingly as well to know when to use which medication. So yep, so looking at another diagram over here, so again, just to reflect, so there's vestibular, there's chemoreceptor trigger zones, vomiting center. So here again, GI, a little bit of central nervous system. So the chemoreceptor trigger zone should be somewhere around here, right? This part of the brain, so it again sends information to the medulla oblongata over here. Right, so here again, just to recap, you can see that there's different receptor subtypes which are present around. So you can see H for vestibular, so you see the H1 and M1 receptors. So those targeting this will be more useful for this section. So you can see chemoreceptor trigger zone, you can see some 5-HT, you can see NK1, right, and some D2 receptors. So you can see that they are non-overlapping sometimes, right? So another diagram, this is from the Orang and Dale book, right? You can see again, because remember the vestibular as mentioned just now, so there's H1 receptors, so again you can use antihistamine for that. You've got the M1 receptors for hyoscine, and you've got the D2, again the vomiting center, right? So you have more that can act here, and you've got some other ones which is specific for the gut, so you can see some that acts on here, such as the NK1 receptors that targets, the drugs that target NK1 receptors. Okay, so again, another diagram to summarize the different receptors on the different sections. So again, it's just it's repetitive, yes. So you can choose which one do you prefer to remember. So let's move on to the first drug in a way. So it's antimuscarinic. So it targets the M1 receptors. So you can see it's mainly on the vestibular section, vestibular cause of nausea and vomiting. So one of the example is hyoscine. It's also called scopolamine, so it depends on UK or US kind of terminology. So it's mainly, as mentioned, towards the vestibular ones. So if you can still remember the information from your peripheral nervous system, it's a little bit like atropine, but obviously it's not such a strong effect, right? So you can have a little bit of dry mouth and so on, dizziness, drowsiness, and so on. So it's limited use in children. So normally the side effects are all right in a way because you're not used for very long term most of the time. So for example, it's available in different types of preparation. So this is a good part of it. There's the normal oral tablets, there's injection, and so on, and even transdermally. So which is good because that's one of the only ones. Yes, I think so at the moment, which has a transdermal patch for motion sickness, right? So so it's, yes, as mentioned, for motion sickness. So it can be used for prevention. So before the trip. So for example, some people are more prone to get motion sickness before a cruise ship, right? Like myself, tried it before. It was awful the next day in the morning after you wake up. So the matching perception of the shakiness of the boat, because the not really boat, it's a cruise in the middle of the sea. Although it's not a very strong rocking motion, but what you see is straight, but your body sense it's moving, so there's a mismatch of interpretation of image or sensation. So therefore, you start to get can get nausea and vomiting. But bear in mind, again, everyone has different degree of tendency of getting it, because I think I'm one of the few ones who feel it, because all the cruise crew, no one felt anything, and they felt that it's one of the normal, very well calm days of the sea. I'm like, huh? All right. So, but if the person feels motion sickness already, like the vomiting and so on, which is quite damaging to the trip in a way, isn't it? Because it's supposed to be a happy trip. It can be used for treatment as well. So bear in mind, it can be also used parentally before anesthetic induction for surgery or after that as well. Because bear in mind, why do we need to use anti-emesis with anesthetic? Because a lot of it actually, after the anesthetic, it's easy. We can somehow, again, it's the brain kind of function and so on, that we will feel very nauseous after getting out, after you get awake, meaning you are conscious after the anesthetic. So it's a pretty common thing, and you actually feel like the whole world is spinning non-stop. Right, so again, some people might feel a bit of nausea and vomiting accompanied after that. So it's also good to give some of them. Again, there's different tendency of drugs of producing such effects. Sometimes it may be good to give hyoscine together with the anesthetic as well, or after the person wakes up. Right, so another part of the whole emesis story, if you remember the diagram just now, is the histamine receptors, because it appears at different portions as well. Right, so you can see there's antihistamines here, such as promethazine, cyclizine, meclizine. So you can see it's the one which is targeting H1 receptors, so it's a competitive antagonist. So again, it's mainly available at the vestibular area and also the vomiting center. So there's a little bit on anticholinergic activity. So you can see and remember, antihistamines, it's a huge group. There's the earlier generation, second generation, and so on. So because you actually want the medication to go into the brain to inhibit the effect and the sensation or the impulse on the vomiting and nausea and vomiting, so you actually want something which is maybe indirectly a little bit more drowsy because it enters the brain. But yes, the first generation one of antihistamines are more effective than the second generation ones because it can go through the BBB. So again, it can be used for nausea, and it can be used for Meniere's disease or Labyrinth disease. So basically, it's something not right in the middle ear. So if you want, you can Google about Meniere's. So that's the medical term. Some of them are diagnosed for that. So if not, then the general simple words for it is called vertigo, which means dizziness. So you actually feel the world spinning around. So sometimes if it's very severe, the person might feel nausea as well. So this is when antihistamine can play a role as well. So bear in mind, these are all the more not so strong anti-emetics, right? So towards later of the class, we'll go through the stronger ones in a way, right? Which targets the what do you call it, the chemotherapy induced ones. So the last one here that we're going to talk about is about the dopaminergic antagonist, so it's phenothiazines. So this is mainly targeting on the D2 receptor. As you can see, the D2, sorry, I can't go back to the earlier slides, but D2 is the one that is other parts of the brain. All right, so and also a little bit on the vomiting center. So this D2 is not on the vestibular side, so it has no role on motion sickness. So but it can target all the other types of nausea and vomiting because that's where D2 receptors are. So common names like metoclopramide, domperidone, right? So and bear in mind, this dopamine receptors are also available at the pharynx and upper GI tract, so therefore it has some role on the GI section as well. So domperidone crosses the BBB lesser, so metoclopramide is the one which uses most. Yes, metoclopramide, it can be used for severe base for nausea and vomiting in pregnancy as well. I got a good dose of that due to my food poisoning last round when I was pregnant. So yes, metoclopramide it's very short acting, pretty effective most of the time. So yeah. So and the toleration, the safety dose during pregnancy is also pretty high, in the third trimester as well, especially. So you can basically get multiple doses of it, right, after the effect is gone. Right, so it blocks centrally on the D2 mainly, a little bit on the D3 receptors in the chemoreceptor trigger zone for the CTZ. Right, so a little bit of peripheral action. So yes, there's other examples, right? Promethazine and all, which has a little bit effect on the D2 antagonist as well. So you can see here, these are the main side effects of the drug. So a little bit of here and there, but again, it's a medication that you won't use for high dose or for long term anyway. So most of the time it's still tolerable in a way, right? Because the first thing that the person or the patient want is just to get rid of the vomiting first. Okay, so let's move on. So here we've got the chemotherapy induced nausea and vomiting. So there's two main vomiting centers which plays a role. So you've got your brain stem. So this is mainly through research we already know that it's mainly the NK1 receptors, right? Or you can call it substance P, right, which actually mediates the vomiting action. So there's another one which is the 5-HT3. So this is the serotonin receptors, so which is mainly at the gut base. So irritation of the gut fiber again. So so in general, as you heard the clinical part of the class first for this one. So there's two phases of CINV. So we've got the acute phase and also the delayed phase. So acute phase can occur very quickly, right? So but the delayed meaning within an hour plus or within the first 2 hours. So but you got delay phase, meaning it's after a day and so on, you can actually have another round of vomiting sensation. So this actually makes the patient quite unwell because that's one of the chief or the main complaints from the chemotherapy. But nowadays, thank goodness, we have better regimen of controlling or managing CINV. So most of the patients are actually feeling much better. So because remember, if they don't feel that bad on nausea and vomiting, they can actually eat better as well, which also helps in their recovery and what you call quality of life as well. Right, so again, if you can inhibit, so you can put antagonists for these two sections. So again, as you can see, we need a combination of drugs to work well, right? Then you can inhibit CINV well. So there's different factors that increases CINV risk. So like younger age somehow, being a girl or female has a higher sensation of all this. Obviously, the anxiety feeling of the chemotherapy as well. Which is going to make it worse. Prior history of nausea and vomiting, people easily get seasick or car sickness. And also somehow a little bit history of low alcohol, not high. Actually, these are the risks that actually can increase the occurrence or the severity of CINV. So we go through the main NK1 receptor antagonist. So if it's available orally, so you got apripitan, so that's the first one, and you got I've got netopitan and rolapitan, so you got IV form as well. So there's a few combinations. So as mentioned, you target the two sections and plus dexamethasone, which is a steroidal drug. So there's different ranking of different chemotherapy combinations. So some medications, as mentioned, they're already known that if the person is on it, it has very high risk for a very severe CINV. So the CINV prophylaxis given will be a stronger one, right? So compared to the weaker, the not so emetogenic chemotherapy, right? So you got other examples. So you can combine like NERPA, for example. So these are the short form for the combination that's used. So for example, NERPA refers to netopitan plus palonosetron. We'll go through the 5-HT antagonist in the next slide, right? So you use somehow reduce the dexamethasone dose in a way, right? I mean, with to this, in relation to this point, if you add in the netopitan, you actually need to reduce the dexamethasone dose given, because it's a netopitan is a moderate inhibitor of the CYP3A4, so therefore it reduces the slow down the metabolism of dexamethasone, so it might cause a greater chance of accumulation of dexamethasone in the body. So therefore, the dose that you give, it has to be a lower one. Right, so there's here I'm just putting some information of rolapitan, which is one of the newer ones. So it's good in a way that the new formulation actually allows it to be, and the drug itself allows it to be given a single dose. Peak concentration is pretty long, about 4 hours. It's a long half-life for 7 days, so which is important in a way to inhibit the delayed CINV, isn't it? Because it's the peak comes after 24 hours up to 120 hours, so it's about a few days there. So you can have one drug, so basically one tablet, which can covers the whole duration for 7 days of effect. So that's great. So bear in mind, because it has the 7 days effect in a way, because the drug sort of circulates in the body longer, so therefore the inhibition of the drug on CYP2D6 will also be longer as well. So other side effects of the drugs are like neutropenia, hiccups, reduced appetite, and dizziness. So let's move on to the second partner in the combination, which is serotonin receptor antagonist. So these are the cetrons. So just now we saw one of the names, palonosetron. You got other ondansetron and so on. So what happened in the cytotoxic drug or radiation? Somehow it irritates the 5-HT. It causes activation in a way, right, of the peripheral terminal in the gut. So therefore send the signal together to top up to increase the circulating 5-HT to trigger at the vomiting center to cause the emesis or vomiting effect. So if you can inhibit the effect over here and here, so therefore again you reduce the sensation of nausea and vomiting. So you have examples like ondansetron, dolanosetron, granisetron, all the cetrons. So among all this, palonosetron is the one with the long half-life. So you have high receptor binding. So again, it's a combination effect. So you can use it for different kinds of nausea and vomiting. Right, so we've got other side effects, again, just temporary ones, right? So I move on. So we've got corticosteroids, which is the third partner. So we know how steroidal works, as you covered in other classes. So, but to be frank, we don't really know exactly what happens, what's the effect. I mean, the action of corticosteroids that actually inhibit the nausea and vomiting sensation. So what we actually proposed in a way is that it actually releases a little bit more 5-HT. It reduces the site inflammation and so on. So short-term use, again, there's some side effects as usual. But so the main theory behind it is that it could have a booster effect towards other medications for nausea and vomiting. So therefore, it is not to be used as a single agent to reduce as an anti-emetic or to reduce vomiting and nausea, right? So common examples are like dexamethasone and methylprednisolone. So we've got other partners as well, like cannabinoids. So as you cannabinoids in a way acts on the cannabinoid receptor, so it's an agonist in a way. So you can see CB1 receptor. If you can flip through the earlier slide, it is also present in the chemoreceptor trigger zone, right? So yes, it can cause. We want to prevent and also treat refractory CINV. So most of the time, it's actually the second line. So meaning if they already got the combination for the earlier good standard combination drugs to inhibit chemoreceptor induced nausea and vomiting. If it doesn't work, so this is the top up ones that we can use, right? So it can cause a little bit of sedative effect. So in a way, that probably explains how it works, because if the person could sleep in a way, you won't feel the vomiting effect sensation, isn't it? So again, as a top up, not to be used as a single agent. So examples like dronabinol and nabilon, right? And you got another example, which is benzodiazepines, again to be used as a combination, as well as probably again for resistant ones. So examples like lorazepam, again to calm down the whole system, right? So a little bit of sedation effect. So again, obviously you don't use at the ultra high dose, which may cause respiratory depression. So another drug, as you can see, olanzapine, you already know that it's an atypical antipsychotic drug. So this medication, you know that it actually targets all around the world. So it actually targets all sorts of different types of receptors, as listed the whole list here. So yes, it can be used as prophylaxis and also for breakthrough as well, again as a top up of the standard therapy. So there's other combinations as well. They can use olanzapine, panolosetron plus dexamethasone, right? So yep, so a little bit of side effects in a way. So this is the last few slides are actually a summary of the whole thing. So hopefully it's going to be useful for you for your revision. Okay, that's it for now. Thank you. Right.